right, great. So thank you all for joining us tonight for our Miami Global Brain Tumor Symposium. Just for some introductions, my name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons at the University of Miami, Director of Research of our Brain Tumor Initiative, and the Director, Site Director for Neuro-Oncology. I'm joined by my co-directors tonight, Dr. Komatar, who's a professor and our residency program director at the University of Miami. He's also leads the Brain Tumor Initiative and our surgical neuro-oncology team. And we have Dr. Morkos, who's in the OR right now. Hopefully he'll join soon. He's the co-chairman of our department and director of cerebrovascular and skull base, as well as Dr. Benjamin, who's an assistant professor and a brain tumor and skull base specialist here at Miami. Each week we put on the Miami Global Brain Tumor Symposiums, but we can't without the help of our amazing administrators, Christina, Ingrid, Ignacio, and Roberto. They work so many hours behind the scenes, and I just want to say thank you so much to them for helping us out each week to make this so successful. If you want to know more about the University of Miami or about our brain tumor symposiums, you could follow us on Twitter at Neurosurgery. All the lectures will be posted on our YouTube channel, which could be found by searching for the University of Miami Neurosurgery. Both the Brain Tumor Symposium and the Cerebrovascular Skull-Based Symposiums are on there. You can also find links at our website at neurosurgery.med.miami.edu. So we have a couple other lectures this week that are happening. As you know, we have the Cerebrovascular University of Miami lecture series, which happens on Thursdays at 5 p.m. So tomorrow, same time, we'll be discussing Moyamoya disease and bypass surgery with two legends, Dr. Steinberg and Dr. Zhu. So please join us for that tomorrow, as well as because one of our panelists is the producer of the Surgeon Log 2020, which is co-hosted by the North American Skull-Based Society. Will be also bright and early tomorrow morning at 6:30 a.m. talking about Petrus apex lesions. And a teaser for our next Wednesday's lecture from the Miami Global Brain Tumor Symposium. We'll be welcoming Dr. Rivas from Brazil. We'll be talking about anatomical guided microsurgery for intrinsic cerebral lesions with our panelists. So please make sure you tune in next week. So some housekeeping before we talk about this week. Participants, please be sure to ask questions at the bottom using the Q&A button. We'll get to as many as we can throughout the night. There's no CME with tonight's lecture, but you will get a confirmation email documenting participation. And please be sure to like, follow, and share our videos so that we can continue to grow and share our upcoming symposiums and the great knowledge of all of our speakers with all those interested in neurosurgery. So this week, we have a great lineup of panelists, starting with Dr. Walter Jean, professor of neurosurgery from George Washington. He's a world-renowned brain tumor and skull-based expert. He's author of Skull-Based Surgery Strategies book, which is one of the best skull-based books out there. He's also, as I mentioned, one of the producers for the Surgeon's Log. We have Dr. Simon Hamp, who's assistant professor and director of minimally invasive brain tumor surgery at Rutgers, soon to be moving to Westchester Medical Center. Dr. Jean-Carl Burkhardt, who is a vascular and endovascular surgeon at Baylor College of Medicine, and Jonathan Brashear is one of my co-residents from UCSF, who joins us as a brain tumor skull-based specialist from Kansas, who is now an assistant professor at University of Missouri in St. Luke's Health System. Thank you to all the panelists for coming tonight. And special thanks to our keynote speaker tonight, Dr. Russell Lonzer. He's really the epitome of what we all want to be as far as a physician, surgeon, scientist. What a great role model for those of us to look up to. He's a professor and chair of the Department of Neurosurgery and co-director of the Neurological Institute at The Ohio State University and the Wexner Medical Center. He's one of the directors of the ABNS, past president and treasurer of the CNS. He's a past chief of the surgical neurology branch at the NANDS and the NAH. He's a tremendous amount of research focused on the nervous system, drug delivery systems, gene therapy, and tumor biology. And he's authored over 300 papers talking about his research. I won't go into all the awards that he's listed, that he's won in the tumor section, and all the editorial boards that he's also on. He's edited to 3 neurosurgical textbooks, of which 2 I have above there. And it's a pleasure just to hear him talk about his work, especially with VHL and hemangioblastomas. So thank you, Dr. Lanzer, so much for joining us tonight and sharing with us your experience.
Thanks so much, Mike. It's really an honor to be here and we've got great panelists, and you guys have done a remarkable job with this. So let me dive in here. Can you everybody see that?
Yeah, that looks good.
Okay. So when I started out at the NIH and continues to this day, we began studying familial neoplasia syndromes, and VHL, or von Hippel-Lindau disease, is the one we probably have the most complete story around, and still a lot to learn. We also looked at NF1, NF2. And so I'm going to focus tonight, though, on what we looked at in von Hippel-Lindau disease, or VHL, and go through what we know thus far. So VHL is named after Eugene von Hippel and Arvid Lindau. And Eugene von Hippel really only saw the retinal hemangioblastomas. It was really Arvid Lindau, pathologist from the Karolinska, who worked with Cushing and Bailey, that tied all the features together. And in fact, Cushing and Bailey named it Lindau's disease. It was only later on that Mehlman and Rosner in the late 50s, early 60s called it von Hippel-Lindau disease. For those of you that don't know, von Hippel-Lindau disease is a result of a germline mutation on the short arm of chromosome 3 that was discovered in the intramural program at the NIH in the early 1990s. The VHL gene is a tumor suppressor gene, has an incidence of about 1 in 39,000 births. It has visceral and nervous system manifestations. The visceral manifestations include renal cell carcinomas and cysts, pheochromocytomas, and pancreatic tumors, pancreatic neuroendocrine tumors and cysts. But the interesting feature, if you look at the histology from each of these are virtually identical. And in fact, the hemangioblastoma histology is identical to this. When we look at the neurologic manifestations in VHL, there's really two: the hemangioblastomas and the endolymphatic sac tumors. And I'll go through both of these, and I'll start with the hemangioblastomas. So about 85% of VHL patients will develop a hemangioblastoma. That number is actually probably higher now that we have imaging and discrete imaging in all of these patients over the years. It's probably pushing over 90%. It's the most common tumor, visceral or nervous system, of the manifestation of the disease. 95% of patients that develop a hemangioblastoma will develop multiple hemangioblastomas. So their management obviously is different than the singular sporadic hemangioblastomas. And when you look at the number, sporadic versus VHL, about 2/3 of hemangioblastomas that you'll see in a patient population will be sporadic. The other third will be in the context of von Hippel-Lindau disease. 99% of all hemangioblastomas, whether sporadic or in VHL, are found below the tentorium, in the brainstem, cerebellum, spinal cord, in retinal. And you see those pictures demonstrating each of those locations here. When we look at these tumors grossly, this is a C6 tumor in a young VHL patient that was resected a number of years ago. Invariably, in VHL, you'll see these form-fruit tumors that aren't imageable on MRI, and I'll come back to that later in the importance of that. You can see the apopeel neovascularization that's robust. On imaging, as you can imagine, with the visual properties of with the vascular properties, these enhance intensely and discretely. So they're actually ideal lesions to track over time. And when you look at these in arteriogram, and this is the AP view of this brainstem tumor just before removal, this 12-year-old girl with VHL, you can see that actually during systole and diastole, the lesion expands and contracts, in this case, about 3 millimeters. And so these highly vascular lesions are unique from the tumor setting. But saying that, I did this angiogram, or we had this angiogram done on this girl almost 17, 18 years ago. We rarely, if ever, now get angiograms on these patients, and I'll come back to that later. When we look at the histology, the first group, Ping Zhuang, who was a molecular pathologist I worked with at the NIH, was the first to discover that as lipid-laden stromal cells, these white cells that you see were actually the tumor cell, were the first tumor cell discovered in these tumors. Nevertheless, as molecular techniques became more sophisticated, they found that there's actually 3 cells in these tumors. One was the small endothelial cells, less than 250 microns. The larger vessels coming into these tumors weren't derived from tumor. They're actually reactive vessels coming in to feed the tumor. And most recently, we found that a third cell, a mast cell, was also of tumor origin. So these tumors are really composed of stromal, endothelial, and mast or blood type cells in them. As I mentioned before, Hippel-Lindau spent time with Cushing and Bailey and as a pathologist, and he had a keen interest in understanding von Hippel-Lindau disease. Based on the gross features that I showed, the histologic features, and that very Cushing hypothesized in the 1920s that the cell of origin in these tumors must be or was related to it must have an embryologic origin. In fact, they used Florence Sabine's early chick embryo data, where she found that during mesenchymal development or mesodermal development, there was a cell in the chick embryo that could develop into blood and as well as vessels. And they hypothesized back in the 1920s that this was probably the cell of origin based on an embryologic model of tumor development. That idea kind of dropped by the wayside, and it wasn't until the 1960s when Art Stein and Robert Whitfield showed in 21 cases the histology of the hemangioblastoma was a mesenchymal appearing in origin. And they hypothesized that, along with Cushing and and Lindau, that there must be an embryologic origin. And in fact, they placed one of these tumors into culture, and they thought they saw red blood cells developing from it, but they couldn't determine if it was from the tumor or not, because they didn't know if it was just blood washing out of the tumor. The idea that Cushing and Lindau hypothesized before went by the wayside because none of these individuals had the molecular techniques to show that this is an embryologic cell. Wasn't in the late 90s showed that there was an embryologic cell during mesodermal development that could develop into vessels, more nature. And what further again could do develop into blood and into vessels. And what they did was they identified this cell during development as expressing three proteins: brachyury, FLIC1, and SCL. Any cell they saw during development or in adult life had to originate from that mesodermal time during embryogenesis, and was again labeled hemangioblast. And what they found is they could develop primitive blood cells, red, white blood cells, granulocytes, all of those things. So a number of years ago, I had a fellow in my lab named Derek Park, who's now head of neurology at University of Chicago, took a keen interest in 2 VHL patients. In total, they harbored 203 hemangiostomas. 25 of those were resected. What Derek did then was did fluorescence staining and found that these cells expressed the FLIC1, the brachyuria, and the SCL. He also confirmed that expression by Western analysis. And what this indicated was that these stromal hemangioblastoma were indeed the embryologic hemangioblast. In fact, Derek put these in culture, found 2 cell populations, ones that were adherent and ones that were non-adherent. In the inherent cells, they had the morphology of endothelial cells you see here, and they used Tie2 and CD31 to confirm that these were indeed endothelial cells. And then there is non-adherent cells, and here's the stromal cells, and you see these non-adherent cells. They using staining, they had the exact morphology of erythrocytes and granulocytes. The real question at this point was, were these coming from the tumors? The same question. We now have the technology, molecular basis, to do loss of heterozygosity analysis. And in fact, what Derek found was that these endothelial cells and blood cells were indeed from tumor origin. So what this confirmed to us is that during normal mesodermal development, you have these cells called the hemangioblasts that can do this, but also these cells are also found in the hemangioblastoma. And what that suggested to us was that, in fact, the hemangioblastoma was derived during embryogenesis. We probably think that loss of heterozygosity for tumor formation occurred during probably the 12th or 13th week of embryology based on the mesodermal development. It also gave us insight in how to manage these tumors potentially. So first of all, we could look at differentiation strategies, which we are right now, to drive these tumors into blood and endothelial cells and get, tumor resolution. It also gave us really deep insight, though, into why the distribution of these tumors is as they are. And if you look at SCL, one of the three markers for the hemangioblast, you see during embryogenesis, it perfectly recapitulates the distribution of hemangioblastomas in adult life, whether they're sporadic or VHL related. And in fact, not only does it do that, SCL is expressed in exactly the same visceral organs that VHL develops tumors in, the pancreas, the kidneys, and the adrenal glands. And so gave us a lot of insight into therapeutic strategies as well as why these develop. And it really supported the theory of embryologic tumor development that Cushing and Bailey, most importantly, that Lindau had hypothesized in the 1920s. While we were doing these molecular studies, we were also trying to understand better the clinical course of the disease. And we did two studies at the time, one with John Wanabo, this first one you see at top, who's now at the Barrow, and then Josh Wynn and Josh Ammerman, who's probably Walter Jean knows, that are in DC. They were fellows at the NIH at the time. And while these were informative, we couldn't really determine what the long-term natural history was. And what we learned during those studies with these tumors had some very erratic growth patterns. So we couldn't tell when they were going to become symptomatic. And we were only treating symptomatic tumors. We weren't treating them based on radiographic progression. So nearly 20 years ago, we started a prospective study that in the objectives were to determine the natural history of hemangioblastomas. Could we determine what features would predict symptom formation and ultimately determine treatment, need for treatment? We wanted to determine the impact of the germline mutation, what type of mutation on the short arm of chromosome 3, that if it had impact on disease phenotype. Most importantly, we wanted to determine the long-term clinical course so that we could better manage these patients. And we've done this with NF2 and NF1 as well. So in 2014, we had accrued the ceiling of patients allowed for that trial, which is 250. We had 225 active patients. 25 became active because 15 had passed away. 9 had dropped out of the study. We were scanning them twice a year. They had to come into the NIH for week-long visits twice a year. So it was a pretty intense study. It was prospective. It's still ongoing. 1 patient consented and didn't come. But this is the patient population we were looking at. 31 females, 119 males. This is an autosomal dominant transmitted disease, so you expect about a 50-50 ratio. Mean age at study entrance was 38.2 years. Follow-up at that time was about 7.5 years. And we reserved surgery only for symptomatic lesions. And this was controversial at the time because there was 2 groups in Europe that had big groups of VHL patients that were operating on radiographic progressions, indicating that they felt that treating the tumors when they were smaller was a safer outcome. So this is our patient population, nearly 3,000 tumors we were following in them. None of this data is surprising. Historical studies have shown this in VHL. 1% of the tumors were supratentorial. Most of these occurred around the pituitary stalk and the optic apparatus. 6% were brainstem. 80% of those were in the obex. Cerebellum, there was nearly half. Most of those, over 60%, were found in the posterior and lateral cerebellum. 36% of these were found in the spinal cord. And 96% of those were found in the dorsal aspect behind the dentate ligament, with 2/3 of those occurred in the dorsal root entry zone. 10% occurred in the cauda equina, roots of the cauda equina. When we looked at growth, we found that there was differences in growth depending on the anatomic location, as you see here. We found that on average, half of the tumors that we saw on scan at patient first visit grew. And this is just the Kaplan-Meier progression curves. The most frequently growing were in the spine, followed by the cerebellum. What we also found was that tumor progression and overall burden were associated with male sex, and that becomes important. And I'll get to that in few minutes. But at the time, there's a lot of anecdotal reports suggesting that VHL is exacerbated during pregnancy. And this wouldn't seem to be correlated with male sex because it was felt that during pregnancy, progesterone and estrogen were driving these tumors for growth. In fact, we know that's not the case now. During that 7.5-year period, 50% of the tumors grow. Nearly all of them grew in a saltatory pattern. These are just the different tumors. Here you see the growth curves over several years. By saltatory, we mean there's a period of growth followed by a period of quiescence followed by growth. And these can do this for years. The average growth period is 14.5 months. Average quiescent period across the series was over 2 years. And many of these never became symptomatic. This was also an interesting fact that we didn't expect. New tumor development decreased with age, meaning this is what we could see on scans. So when you go back to that gross image I showed you during surgery, we all saw those form first tumors that were never identified on MR because they're just below the threshold of detection. So these were tumors we could see on MR. But you can see after the age of 40, there was a significant decrease in new tumor development, suggesting that if you can keep these patients at a normal neurologic function by judicious surgery and indications, you could preserve normal function over time throughout their lifetime. We also found that if you had a missense mutation or a deletion as your germline, you had significantly less disease. And we now think we understand the biology about what was causing that versus a partial deletion has much more disease. And I'll come back to that at the end. Only 9% of tumors over 7.5 years of those 3,000 tumors became symptomatic. Mean age of symptom formation was 33 years, and that was very typical. That's been reported in the literature time and time again. You'll see these larger reports of VHL anywhere between 32 and 34 years of age. So it's very consistent. As you can imagine, based on the locations, the preferential locations in each of these structures, the cerebellum, brainstem, and spinal cord, we saw differences in symptomatology, not unexpectedly. 76% of patients with symptomatic cerebellar hemangioblastomas had headaches followed by ataxia, dysmetria. In the brainstem, the posterior aspect lent itself to hyposthesia, eventually gait ataxia, dysphagia. And in the spinal cord, the incredible predilection for the posterior aspect of the spinal cord and the dorsal root entry zone make it not surprising that hyposthesia sensory changes were found in 83% of symptomatic tumors. Later, weakness and gait ataxia also were signs and symptoms found with symptomatic tumors that led to resection. What was interesting, though, we found is of the symptomatic tumors requiring surgery, a little less than half of the tumors that eventually produced symptoms were never seen on initial imaging. So when you saw a patient come in, you could never predict which of those tumors would become symptomatic. And in fact, in that 7.5-year period, had we operated on radiographic progression alone and not symptoms, patients would have undergone 3 unnecessary surgeries during that period. And if you extend it now, we have over 10-year data, it would have been 4 unnecessary surgeries over a decade in tumors that just had grown or showed some type of progression, either syrinx or symptom or edema formation. The other interesting features, though, we found is that almost 90% of the tumors, the hemangioblastomas that became symptomatic, had a peritumoral cyst. So we looked at that in 2 studies, one in 2005 and one in 2015, where we captured the development of cyst in 132 patients in that larger series below, and in 16 patients where we tracked the development deliberately of 22 hemangioblastomas, and we looked at cyst fluid in those patients. And here's what we found between those 2 studies. No matter whether the hemangioblastoma is in the spinal cord or in the cerebellum, it follows a natural sequence of those tumors that form peritumoral cysts. And by that I mean cyst at the edge of the tumor, not the things you see with a GBM, a necrotic GBM or necrotic metastases. These are just fluid cysts at the edge of the tumor. But they all followed a very distinct pattern. They formed as a tumor. You start to see early edema formation in either case. And then over a period of years, a cyst develops. And the timing for that from edema to cyst formation was 3 years, but it was highly variable. So we couldn't even correlate a precise timeline from when edema formed to cyst formation. But what we saw in every single tumor was all of them went through a phase of edema formation before cyst formation. And so we still weren't entirely positive of what was causing this edema to cyst formation and what was the mechanism behind it. And why would a tumor form edema first always in a cyst? Because it was controversial at the time. A lot of people, VEGF had was playing a big role in the basic sciences. People said there were VEGF receptors that were triggered by these hemangioblastomas, or there was an autocrine-paracrine loop with tissues in the cerebellum that would cause these cysts to form. Well, we had a very bright neuroradiologist, John Buttman at the NIH, and what he was doing was, while we were scanning all these VHL patients with post-contrast scan, he was doing flare scans pre and post-contrast, and that became very important because flare is 10 times more sensitive to contrast in fluid. And what John was seeing in each of these cases was we would do the pre-contrast flare, we'd give contrast, and then you would always see contrast leaking out, and it was settling in the back of these cysts. And the interesting part about the settling in the back of the cyst is gadolinium is more dense than cyst fluid or CSF. So patients on their back, the gadolinium is going to settle to the back of the cyst. And in fact, we saw the same thing in spinal cord tumors. This was a young girl we had just before surgery. She had an immediate MR scan. 2 hours later, we saw the contrast extravasating out, almost looks like a diffuse glioma in the spinal cord. And at 6 hours, you see further diffusion. And it led us to the idea from a mechanistic standpoint that these tumors must be leaking fluid, or contrast in this case, from the plasma into the surrounding area, causing edema. Once edema forms, the body reabsorbs it. But once the capacity of that immediately surrounding tissue is overwhelmed by the amount of fluid, a cyst forms. And the reason a cyst form is important is because it's a very biologic way to create a bigger surface area. A cyst is bigger than obviously the immediate tissue around a tumor to absorb fluid. So it permits a fluid to be better absorbed, and so a cyst is a natural mechanism. And so what we were also doing was tapping the cerebellar cyst fluid before removal, and then we were comparing it to plasma ultrafiltrate by 2D gel electrophoresis, and we found the exact protein content in the cyst fluid as the plasma ultrafiltrate. So simply all this is there are leaky vessels in the tumor that allow plasma ultrafiltrate to leak out, edema forms. Once the edema overwhelms the capacity of the tissue to absorb in some of these tumors, it forms a cyst for maximal reabsorption. So given a lot of data, but I just wanted to come back and tie that to what it means, because this was ultimately what we were trying to do with these studies, is figure out what would the impact on managing these patients, VHL, and ultimately sporadic patients. The first kind of conclusion we came to was obvious to everyone on this Zoom call, is that hemangioblastomas can cause significant morbidity due to size, location, and edema cyst formation. The edema, as we mentioned before, precedes cyst formation is a result of plasma extravasation through these leaky tumor vessels of the tumor. This has profound implications for therapeutic modalities that can increase or decrease vascular permeability, so stereotactic radiation or chemotherapy. And this could answer some of the questions as to why chemotherapy has not been effective, although some people have seen symptomatic relief. Stefan Richard and Bill Kalin both published a small series of patients in the American Journal of Ophthalmology, and I think Bill Kalin may have done his in ophthalmology. But what they found was they were giving a VEGF receptor inhibitor, which, like Decadron or any type of steroid type paradigm, would reduce permeability. And what they found in these patients is they were giving it for patients losing vision for retinal hemangioblastomas. And they found that these patients' vision got better, but the tumor didn't change in size at all. And they were tracking edema and things like that, and found it was just simply a reduction in edema. And this is what stopped these studies from going further. The saltatory growth pattern that all these tumors exhibit when they begin to progress has implications for radiation. So we all know that if you have SRS, if you can stop the tumor from growing, it's considered success. Similarly with chemotherapy, if you can stop tumor growth, again, considered successful. But imagine if you treated, this is a number, the tumors, and 4 tumors for 1 patient. If you gave SRS to a patient here right after progression, and they became quiescent for 2, 3, 4 years, you'd think you'd have a striking success. So we looked at this in a prospective study. Ashok Astigiri now at UVA did this. 20 patients, 40 hemangioblastomas of the cerebellum or brainstem. They were ideal tumors for radiation based on size. They were given conventional high doses of stereotactic radiation that are consistent with the modern era. And we tracked those patients for a number of years. And these were done at MGH, they were done at Pittsburgh, UCSF, and the NIH, these patients. And so here's what we saw. This is the progression curve of these tumors that were radiated. And in fact, by 10 years of follow-up, 50% had already progressed. And if you superimpose that Kaplan-Meier curve for the 3,000 tumors, the hemangioblastomas that we looked at on this, prior to, what you'll see is that in this blue curve, that it's no better than the natural history at about 8 years, suggesting that there's a very potential for limited use of stereotactic radiosurgery in these cases, and patients that can't tolerate surgery, as well is where you're looking for short-term control, because by about 8 years, like I said before, we didn't see any better control and progression than the natural history would dictate. And in fact, just to further emphasize the consistency with other studies, what we saw at 2 and nearly 5 years was 93% control rate. The prior studies had really looked at, though none had gone on beyond 5 years. And that's why there was this perception that stereotactic radiosurgery had a potent and lasting effect. Most of these tumors remain asymptomatic, not requiring treatment. Tumor progression, a presence of a tumor, or radiographic progression is not an indication for treatment. We still use very, very early symptomatology to indicate the need for treatment. What we've learned by managing these tumors is that once defined lock deficits or more profound deficits occur, we cannot reduce them in the vast majority of cases. But nevertheless, these tumors most of them have an extramedullary and intramedullary component. They have very discrete borders, and you can resect them safely in the vast majority of patients. So surgery remains the gold standard for the management of these tumors, but only at very early symptom formation and not radiographic change, because you will put patients under unnecessary surgery over their lifetime. Decreased hemangioblastoma formation that we saw with the missense, and these are the 40% of germinal mutations in VHL are missense. And what we found through biologic studies is that these patients maintain in their VHL protein, which is this protein transcribed from the VHL gene, still retains intrinsic function. And the reason these patients develop tumors is because that somewhat dysfunctional protein or protein, the VHL protein, is destroyed so rapidly. And so we began looking at strategies to inhibit that with histone acetylase inactivators, and have a pilot study that we're working on right now with that to see if we can prolong that by reducing the proteostasis or proteolysis of that protein. And in animal models, we saw that we could reverse VHL tumor progression in those cases. So we're looking at that. But what it also explained to us is, so why do these patients that get older develop less tumors? Well, there's an interesting phenomenon that occurs with age. The fidelity of that proteolytic mechanism that's destroying the mutant protein becomes less effective. And so that probably explains why, as you get older, some of the protein can still be functional, and we see less of these tumors develop. So finally, for the hemangioblastomas, what we see here is they're benign tumors with frequent cyst formation. They have a saltatory pattern of growth. Surgery remains a treatment of choice, and we've now identified biologic pathways for treatment in understanding these tumors. The second and only other neurologic manifestation of VHL is lymphatic sac tumors. And for those of you that aren't familiar with the lymphatic sac, it sits, if you're looking at this rectal labyrinthine posterior putrescectomy approach, it sits in the anterior dura of the posterior fossa, sigmoid sinus here, semicircular canal shown here. It was Dennis Hefner that discovered these only in 1989. He looked at 20 cases. He was a pathologist at AFIP. He only had autopsy specimens, so this CT is not from his series. But what Hefner did was pretty ingenious. He just drew a line through the center of these tumors in situ. They always, where they crossed, landed over the endolymphatic sac. He also looked at histology and showed that there was endolymphatic endothelium that was the histologic portion of it, of the tumors portion of it. And what he hypothesized at the time was that these must be originating from the sac. And he said that the hearing loss, because all these patients were deaf pre-mortem, must be due to otic capsule, which is the bony capsule around the inner ear apparatus, was destroyed and caused hearing loss. But he said in time, there were probably other mechanisms that he couldn't discover at the time because the patient the autopsy series that he had only demonstrated these large tumors. And in fact, he didn't call them endolymphatic sac tumors. He called them probable adenocarcinomas of endolymphatic sac origin. So Ed Oldfield and Tom Mansky looked at a series in 1997 of patients with endolymphatic sac tumors in VHL and imaging. 15% were bilateral. 11% of the patients VHL had them. Mean symptom onset was 22, so earlier than the hemangioblastomas. In hearing, audiovestibular complaints were found in 2/3 of VHL patients as a first symptom. They found a triad of the most common symptoms were hearing loss, tinnitus, and vertigo, identical to Meniere's. Most of these patients in VHL were diagnosed as Meniere's disease. What was striking, though, was almost 90% of the patients with hearing loss lost it suddenly. So what that means is within less than 24 hours. So some patients would go to bed with hearing, wake up with profound hearing loss or some type of hearing loss, or they'd be talking on the phone and lose hearing. That's how sudden it was versus gradual over years. There are two questions that paper came out of that paper. Was on imaging evidence of an ELST, 80% had no otic capsule destruction to explain the hearing loss. And in patients with VHL and no evidence of ELST, 2/3 of those had hearing loss without an environmental cause for it. So those were two potent questions that were ultimately answered by a series of 3 patients that we looked at over a decade ago. One was an autopsy patient. A patient had died of renal cell carcinoma at an outside facility. His bones were, the temporal bones were at the Mass Eye and Ear, and they were kind enough to give it, let us analyze those. But here's that patient's MR. Clear ELST here on the right side, nothing on the left, but he was deaf in both ears. When we looked at this left ear, in that bone, temporal bone, we found that there was evidence of an endolymphatic sac tumor in the endolymphatic duct, actually. And we also found that there was bony erosion around the endolymphatic duct, evidence of hemosiderin within the endolymph, evidence of hydrops, and cochlear nerve degeneration, suggesting that blood or hydrops could underlie the cause of this hearing loss in these patients. The second of those 3 patients was a young woman, VHL, she was from the McCoy family, and the Hatfield and McCoys, as an interesting side note. The McCoys were thought to have VHL, and this is what some have hypothesized caused rage and caused this ongoing conflict with the Hatfields. But in any case, she developed tinnitus and vertigo, was friends with a very prominent neurologist in the area, immediately got a audiogram, showed very little hearing loss except in high frequency, put on steroids and salt restriction diet. It improved over several weeks. A year later, she had vertigo, tinnitus that was severe, and hearing loss. Audiogram right within a couple of days showed moderate hearing loss across a number of frequencies. She was referred to us again a year later with complaints again of tinnitus, vertigo, and here's her imaging. We now see blood on this non-contrasted scan within the inner ear apparatus. We see a small ELST now within the duct, and you can see erosion in the CT scan and further progressive hearing loss. And finally, the third case was a gentleman from Hawaii that had very little evidence of anything. In fact, this is an endolymphatic sac and was read as normal for years. You can see some erosion in the endolymphatic duct area. We went ahead and resected him, and Walter knows Jeff Kim, who's a neurologist, worked with Walter and worked over at the NIH as well. Here's an endolymphatic duct, and you see a small 2 by 3 millimeter tumor within the duct, and here's the histology, suggesting to us that there was multiple mechanisms for hearing loss, not just otic capsule destruction. When we looked at these patients over a series of years, what we found was the tumors weren't even originating from the endolymphatic sac. They're always originating from the endolymphatic duct. You can see this here, same patient I showed before. And we saw this time and time again with patients developing ELSTs. And this becomes important from a surgical standpoint because we didn't want these tumors to get big because they were causing unpredictable hearing loss, but it also gave us an anatomic target to operate for, in particularly those cases, as I mentioned before, that didn't have any evidence of imaging, but had evidence clinically of an endolymphatic sac tumor through audiovestibular complaints. Well, at the time, when Jeff and I were originally looking at this, people were not operating on ELSTs because they were benign, slow-growing tumors. The fear was that if we interrupted the endolymphatic duct or sac, we would cause hearing loss iatrogenically through surgery. So we began to look back through the ENT literature because they shunt Meniere's disease all the time without hearing loss. And Shuknik, who was the chair at Mass Eye and Ear, had some very important studies where he showed that the revived directional valves at these ductules that go into the saccule and into the utricle that, depending on pressure, can prevent indolent from leaking out, but you can resect the entire duct safely. So we took a very different approach to managing these tumors based on that. But it was the mechanism of understanding these bidirectional valves. And here you have the endolymphatic sac, duct, cochlea, semicircular canals, these two ductules. And what happens during normal physiology is as pressure builds up in the endolymph of the inner ear, what it does is the bidirectional valves open, endolymphatic fluid goes into the sac and it's reabsorbed. If it's not, or if you have problems with that, you get Meniere's disease. So that drove us to say, what's the mechanism of hearing loss if you have a tumor in the endolymphatic duct? And what happens in that scenario is you could have endolymph pressure building up, it's not reabsorbed, and you could get progressive symptoms like Meniere's, the hearing loss, vertigo, the tinnitus. And in fact, we probably should have redesigned this because if you look at the hemangioblastomas, we don't know if this is through highly permeable vessels leaking fluid into the endolymph and causing that gradual triad of those audiovestibular symptoms. The final was we clearly saw blood on those scans. And if these tumors bleed or cause bleeding in the inner ear apparatus, you could understand how you could get instantaneous hearing loss with cochlear nerve degeneration, which is a common phenomenon known for any type of irritant inflammation within the inner ear can cause cochlear nerve degeneration, and blood would obviously do that, what we saw in many of these scans. So the final piece of this is we looked at it in 35 consecutive patients, 38 ELSTs, so 3 of them had bilateral. Interestingly enough, there's a predilection for the left we can't explain, and this is not just our series, it's others. Average age of symptom onset, 31 years, and we follow these patients for almost 8 years. They had the same triad Ed described before: hearing loss, tinnitus, and vertigo. Again, presents like Meniere's, so if you have a VHL patient with Meniere's symptoms, a good chance they have an ELST. And what we began to do, though, was break down the 3 mechanisms we had proposed. The first was otic capsule invasion that Hefner proposed in '89. We had 7 ears of the 38 that had that. All of them had, not surprisingly, sensory neural hearing loss. What we were most interested in was the ears that did not have otic capsule invasion, 31 of 38. We asked the question, do they have sensory neural hearing loss? In 4 ears of the 31, they didn't. There was no evidence of intralabyrinthine hemorrhage. These patients had normal hearing. In the patients, the 27 years that had hearing loss, we looked at whether it was sudden or gradual because of the 2 mechanisms. You could see high drops being gradual, blood being sudden. 14 of the 27 years had sudden hearing loss, and we saw intralabyrinthine hemorrhage in nearly 80% of those. In the ears with gradual hearing loss, none of them had intralabyrinthine hemorrhage. So when we looked at that data, some not surprising things came out. If you had otic capsule invasion with hearing loss, you typically had a big tumor. This suggested maybe we need to get real aggressive with these tumors, which we were at the time. The no otic capsule invasion, they just hadn't eroded through the bone into that area. What was interesting, though, is with the no otic capsule invasion, and we looked at size, patients with normal hearing versus moderate versus severe to profound, we saw no differences in hearing loss across this cohort, which suggested to us in Ed's original series that he published in '97, they saw a difference in hearing loss that they correlated with size. And you can see why most of those patients had otic capsule invasion. But here, what this suggested is the size was not an indication or was not associated with the factor of hearing loss. So we needed to operate on these tumors early before they could cause problems. And this is just data, like I said before, 80% of patients with sudden hearing loss had evidence of intralabyrinthine hemorrhage. And so what that kind of cemented us into is there's three causes of hearing loss. Or otic is a really far progressive cases where it's eroded into the inner ear apparatus. The other scenario is if there's blood, where we believe there's acute hearing loss. And finally, there's hydrops, where the lymphatic system through the bidirectional valves or pressure cannot be relieved because the tumor is not allowing it to be reabsorbed in the sac. And so what this did was definitely change our indications for section. We're no longer watching these. We were operating on patients if they had an ELST seen on MR imaging. We then began to operate on patients where with VHL that we did not see an ELST. If we saw hemorrhage in the labyrinth with symptoms, we would operate. The one question really had hydrops. We couldn't image it at the time, which was over a decade ago, but in the last several years, we were able to do that. And John Buttman, again, was behind us with delayed flare imaging. And what he was able to demonstrate was hydrops. And so we began operating on patients with VHL and hydrops with no imaging evidence of an ELST, because these were so tiny, like you saw in that first guy with the that had an autopsy, that they were creating endolymphatic flow problems. And so we've explored over four or five of these patients now, all without imaging evidence of an ELST. All of them have ended up having an ELST that demonstrated hydrops on their scan. And so the last piece of this is understanding the origin of these tumors became important. And here you see the sigmoid sinus. We do all of these small tumors through a retrolabyrinthine posterior petrosectomy to preserve the semicircular canals. Here you see the endolymphatic duct. We're opening that duct in this patient. And in fact, you can see that's splitting the duct right there in half. You can see the endolymphatic tumor. And in this case, scraping the tumor out and removing this microscopic tumor, which was not evident on MR imaging. And so now we can target the very precise origin now that we know it's in the duct, even if we can't see them. So patients do well. This is the first 31 consecutive patients that Jeff and I operated on at the NIH, 33 years. Hearing remained the same in virtually all cases. The three that improved, to be honest, were patients that were caught within 1 week of hearing loss. The rest, we didn't expect any hearing improvement. We resolved tinnitus, vertigo, and oral fullness, the audiovestibular symptoms by surgery. So you can reverse those. So here, even in patients with profound hearing loss with audiovestibular symptomatology, it's worth operating on them to reduce those symptoms, which are incredibly disabling. So as far as the ELST goes, these tumors underlie significant audiovestibular morbidity. Three mechanisms of hearing loss or audiovestibular morbidity are the otic capsule invasion, blood, and hydrops. Surgical resection is a treatment of choice, and we don't wait for symptom formation if we see a tumor. It's very different management style than what we do with the hemangioblastomas. So I'd be happy to take any questions. And thanks again, Michael, Rick, Jacques, for allowing me to be on this presentation.
Thank you so much, Dr. Alonso. That was outstanding presentation with so much great science. So congratulations on all of your work, of you and your team. You should be very proud. A couple questions I had was, for VHL, you were talking a little bit more about the missense and the partial deletions of the genes. So how close do you think we are to doing gene therapy on those patients and trying to, as another way of therapy for them?
Yeah, so I think, CRISPR would obviously jump out as a potential option because, you could repair all of these things. I think we're years away, 5 to 15 years away from that. And it depends on what we see as the downstream problems with CRISPR. I think the gene therapy strategies are still going to be a ways out. I think we'll be operating on these for probably at least the next decade. Chemotherapy, interestingly enough, the ones that, and it's been tried in VHL a number of times, from VEGF inhibitors, propranolol, all these things we've not seen impact on changing the progression of the disease.
And then one other question I had was, when you were looking at the natural history of VHL, did you notice any difference when somebody just had one hemangioblastoma versus multiple, and how that would affect them, or not really?
Yeah, we looked at that, and we thought we would get some association out of that, and we did not. And you know, there's a lot of ideas that we had going in, or hypotheses that were actually not proven. We thought there was a systemic, you know, hormonal thing because of the young age. You know, just, you know, these tumors arise and we're growing after puberty. We never saw a consistent growth pattern across all the tumors. So that's still a huge black box at this point.
And then there's a comment here from Dr. Rivas about, in the beginning, you talked about the role of embolization and angiograms, and how you kind of grown away from those over time. I think a couple of people wanted you to comment a little bit more about what your current protocol is for preoperative workup and angio-embo.
So I think, you know, probably operated on, if you include spine and everything else, probably 800 to 900 of these. We've embolized one. And, you know, when you look at the data, particularly from the French group around posterior fossa, the risk of embolization versus the risk of microsurgery, it's not even in comparison. They had some pretty dramatic disasters from the embolization of posterior fossa hemangioblastomas. So in saying that, even if you can embolize the main feeders, there's a number of microfeeders that are still feeding these hemangioblastomas that you have to manage at the end of the day. So the only time we've ever done angio, I can count it on less than 2 hands, is really big tumors where we're trying to get a vascular roadmap before surgery. It's been over a decade, though, I think, that we've even done an angiogram.
Great. Any other questions from the panelists? Otherwise, I think we'll get to the cases. Walter, you want to start?
Let's see. Why is it not letting me share my screen? I'm having a little bit of trouble sharing my screen. Anybody got?
Do you have the PowerPoint already open?
Yeah, I do. All right, maybe yeah.
Should be able to go to the screen, the green one in the bottom. And
Yep, I'm hitting that, but it's giving me some very strange content of second computer. I don't know why that. All right, maybe someone else could go first.
Yeah, let's Jean Carl.
Hi, sure, I can go ahead. Let me try to share my screen. Is it working?
Not yet.
Not yet.
I think I might have your slides though. Let's see here. Let me try. I think I could share them here.
Hold on.
Any luck, or do you want me to go?
Yeah, I can't really share them, unfortunately.
Oh, we can see it.
All right, that's from me. I just have your PDF file, so.
Yeah, okay. Then let's do that.
Okay.
That's fine. Can you go to the next slide, Ben? So I kind of want to present a case. It's already an older case from 2010, as you can see here. And I quickly want to thank also one of the residents from Zurich. So I trained in Zurich, and I worked as an attending before I came to the US. And that was a case I saw early on as an attending. It's a 31-year-old patient. And actually the resident who helped me was Bas. I thank him for the slides because I don't have any Epic access in Zurich anymore. So this patient presented in 2010. He was actually a refugee who came to Switzerland at that time and was diagnosed with VHL at that time, with hypertension, was treated for his pheochromocytoma, presented also with elevated ICP and received a shunt, and had at this point multiple small cerebellar and spinal hemangioblastomas. None of them needed treatment. He was not symptomatic. But then 2 years later, he presented with this cystic hemangioblastoma who increased in size and was treated for this lesion. One of my colleagues treated this patient surgically, and he left the hospital afterwards, and I took over basically the care of the patient. Can go to the next slide, please.
Mm-hmm.
When I saw him post-op, so he had these multiple small lesions, and this is my first questions to the panelists. So how often do you follow up on these patients? So if you have a patient with small hemangioblastoma lesions, do you do like a 1-year follow-up MRI or only based on progression of symptoms?
That's a great question, because if we're saying symptom formation is a driver for indications, in theory, you would wait for symptom formation. Unfortunately, most of these, the symptom formation occurs so slowly over time. So in this case, I would watch in a year, and if as I began to know the patient more and more, I'd push out to 2 years, sometimes longer. I don't know how everybody else would feel about that.
Yeah, I mean, what was the time point between this? This was just 6 months.
Yeah, this is basically post-op, kind of, yeah. Give you a baseline. So diagnosed was 2010, and then 2012 he was operated for this cystic hemangioblastoma. So I kind of decided to do a follow-up in a year. We can go to the next slide. And one of the lesions became larger, as you can see here. He was very nervous that these lesions would grow because he didn't really like the experience that he became very symptomatic. Here he was a little bit ataxic, but not really like a lot of symptoms. But I decided in this situation to take this lesion out because it was also kind of a straightforward surgery. And you can maybe go to the next slide. It was uneventful, small suboccipital crani and resection. It went very well. And then you can go to the next slide. The question was then, okay, it jumps already. Yeah, it's not in the PowerPoint format. But my question was then, how do you follow up the patient over long term? Do you continue just observation, or since he had like 2 progressive lesions, would you consider also any other medical treatment? We heard about chemotherapy or systemic treatment or radiosurgery preventively to prevent the progression of these lesions.
I wouldn't use either of those modalities, particularly in a young person. Surgery is going to be the only thing that will fix them, because the chemo, we don't have anything that will manage that patient with chemotherapy currently. And the radiation in this young person won't last, another decade. We saw the progress through it. We even saw tumors shrink after radiosurgery, then regrow again years later. Anybody feels differently though?
Yeah. Yeah. So
it does bring up that question though of symptomatic progression and these people who already have had 1 surgery in the posterior fossa and they're already having some ataxia, and things could change over time just with age, and they could say their ataxia is getting worse. Sometimes it's hard to know if that second lesion is really symptomatic or not.
Yeah.
Do you feel like that was the case here, or was it pretty obvious then?
So here the symptoms were not very obvious, to be honest, for the second surgery, and after surgery he was basically the same. He was a little bit ataxic, but that was also since the first surgery, so it was not really like clear symptoms. Here I want to kind of highlight. So we just followed him for a year, and then in 2015 you can see there was like some progressions of his non-cystic, like more solid hemangioblastomas, and at that point we actually decided to start Avastin therapy on him based on a tumor board together with our neuro-oncologist. And so it's hard to say if it actually helps, but till 2017, everything was kind of stable. So nothing happened in terms of growth. And then, so in 2016, I left to the US, and then I gave the care to somebody else. And if you go to the next slide, the story is not over yet, unfortunately. He presented again symptomatic with 3 new lesions in 2018, although he was on Avastin, and also so he was resected for these lesions. He also had like shunt removal, revision due to infection and malfunction, and then he also progressed in his cervical lesion, which I didn't want to show. It's too many images, but he received radiosurgery for that lesion. And unfortunately, also because of the multiple surgeries, that's what I'm assuming, and also Avastin, he ended up with some bone complications, needed revision surgery, removal of the bone flap in the posterior fossa. Right now, he's actually doing okay. I asked the resident in Zurich, so he's stable, no new progression. And now, if you look at the age, and we just learned he's now about 40, so hopefully it's slowing down and he doesn't get any new lesions. Yeah, but we will see what time will tell. I thought it was just an interesting case to show that it's really, it reminds me a little bit from a vascular neurosurgeon perspective, like these familiar cavernous malformation patients who have like different lesions, and you really have to follow them over a long time, and you have to consider that you need to do surgery on them, like maybe a few times in their lives, and you have to be very careful and mindful about the incision and what you do, and just be with them for a long time.
Yeah. No, Jan, this is great. I mean, it shows a lot of the stuff like, so the symptomatic lesion you see on that right anterior cerebellar piece wasn't seen on scan. And that's what we saw, that almost half the lesions we operated on, we never saw in the initial scan. And that would be this patient's case. We also saw the radiographic progression after stereotactic radiosurgery, which was seen here. Avastin was very appealing from a biologic perspective, but it was the same phenomena that at some level that Bill Kalin and Stefan Richard published about attacking the VEGF type mechanisms, and those actually never impacted the tumors. And even we have these discussions around our oncologists wanting to use Avastin, and we've had to kind of stop that because it's never been proven to benefit, and it only creates more problems, from a surgery. So in my mind, and others may disagree, this is purely a surgical lesion still.
Yes,
so,
yeah, I agree.
And so if you were coming in from the right cerebellum, then, even if there were lesions that weren't growing, you would just take out whatever would be accessible via that approach. Is that your general approach, Dr. Lanzer?
Yeah, so, and I'll be honest, we would even target just simply that symptomatic lesion. And in many cases, even if we saw some small 2 millimeter tumor on the surface, we wouldn't necessarily take it. Because again, and this story is beautiful because it really nicely shows that you can see many of these tumors just remain stagnant for long periods of time.
Okay, great.
Okay, great.
Let me try mine again.
Sure.
Yeah, I think
go.
we're good this time. Thank you. Before I start, thank you for the invitation to speak. I want to emphasize one point that Russell made, which is very, very important. The edema that eventually forms a cyst, that also impacts on the surgical principles for hemangioblastomas very heavily. That means that do not resect the cyst. Do not think that cyst is somehow like a pilocytic astrocytoma. It's a totally different ball of wax. So you take out the nidus, that cyst, leave it alone. And that's a very, very important principle on hemangioblastoma surgery. I'm going to differ with Russell about the angiogram thing, and I think here we go on my case. This is a woman in her 50s with on Hippel-Lindau and a previous hemangioblastoma. She thinks of the lower cerebellum. She does have an incision to prove it, but it was a long time ago. She came to me when she had gradually progressive ataxia, and he shows up with this giant thing in the upper cerebellum. So if everything is 99% is infratentorial, then this is certainly as high as it can ever get in a very steep tent. So, you know, I'm a skull-based surgeon. I like to talk about approaches and whatnot. And this is, you know, less of a basic science sort of dilemma, that more of an approach dilemma, I think, because of her particular anatomy. Mind you, she's also 300 pounds. So I'm surrounded by trigger-happy angiographers. And for me, and I like to pretend I'm a vascular surgeon once in a while, much to Jacques Marcos's laughter. I think of these as AVMs, and having a roadmap is critical, mainly because I don't want to take that big draining vein at the start. I want to make sure that I'm going around it. I've got enough exposure to come around it. I cannot take this piecemeal. She would die from hemorrhage. So I think angiography is important in one regard like this, and I'll show you another case where it might be important for something else. But again, you have to think about these as AVMs, and you have to have enough exposure to come at it from an en bloc sort of a way. And I would stop there and ask Russell how he would approach this one. It's a reason.
Yeah. So this is one of the ones I don't disagree with the angiogram on this, because it's just too noisy with the veins, and you know, these are rare. Fortunately, these are tough. Obviously, so we've gone at these a couple of different ways. Supracerebellar approach. We've done them transtentorially, subtemporal transtentorially in some cases where we don't have a venous vein plugging in, you know, to block our approach. Those are the two main ways we look at it. I think this one has a nice cyst below, so I would probably do, you know, a lateral supracerebellar. It doesn't really go to either side. So I just do a straight supracerebellar approach, and use that cyst as a little bit of a corridor of access, but take off that probably about a 2 millimeter rim of the superior posterior cerebellum.
Okay. Yeah, I think of the tentorial angle this particular way. I use this reference line, which I've written about and published about. And turns out that her angle is very, very steep compared to the general population. So what we end up doing for her is putting her lateral and going into hemispheric occipital and transtentorial, which I find, you know, I don't remember why I put her left side down, but I did put her left side down, and you know, let the occipital lobe fall. And then I'm showing you a right-sided picture. I'm sorry I don't have a left-sided picture. But the occipital lobe falls very nicely away from the tentorium. You see the straight sinus, you cut the tentorium, and boom, you're right there at the cerebellar vermis, and this thing is widely exposed for you to be careful with the vasculature and taking this thing on block without having a large hemorrhage. So my second reason for angiography in some of these is the sporadic cases that Russell didn't have much time to talk about. This was a 47-year-old man that I got duped on. His chest, abdomen, pelvis was completely clean. I had no reason to really believe that this was a MET, but for whatever reason, I thought this was a MET. And I didn't think of it as a hemangioblastoma, and I didn't think of the need for an en bloc resection and whatnot. And I ended up losing a leader on him, because I went in thinking that it was a MET, that I could core it out, and then boom, I got into the middle of a hemangioblastoma, and lo and behold, blood transfusion, got into a big fat mess. And in this one, if I had to approach it, if I knew it was a bloody tumor, or approaching like the AVM thought again, I might have gone transtentorial again from the top, so I can have a much wider space instead of climbing that steep hill and going retrosig and whatnot. So here's my second point about the angiogram. Sometimes in these sporadic cases where there's barely any cyst to sort of hint at a hemangioblastoma, the angiogram would tell you whether this is a hemangioblastoma or not. And that, you know, in this particular patient, it would save him a liter blood loss and several blood transfusions, and me a lot of heartache and nervousness. So that might be a diagnostic reason why an angiogram could be useful. So I will end there and let you let Russell comment about these.
No, Walter, those are great points. And I think, you know, it's in this scenario, I probably would have. These are so rare on the anterior side. I think probably a dozen of these out of the entire series had to approach this way. That tent was incredibly steep. But I mean, I think that interhemispheric approach, particularly in that scenario, is you know, after what you showed, it's absolutely the right approach. But I do think angiogram in these, where you're in a very noisy venous and arterial area, makes sense. It's just they don't occur that frequently here.
But I
You
would
have to
completely
have-
100% agree with you about not embolizing these, because
Yeah.
again, there have been reports very clearly documenting horrendous disasters. And I think it's quite well agreed that embolization is very, very, very scary. I will leave with this slide already. Mike has already helped me with this, but see you all tomorrow for the NASBS webinar early morning. Thank you very much for having me.
Good points, Walter.
Thanks so much, Walter. Simon?
Sure. I'm going to go to share screen.
Right.
Thanks so much for having me. Really appreciate it, Mike. This is great. You guys able to see it?
Yeah, just hit presentation mode.
Yeah, presentation. How's that?
And then swap displays.
Okay. Does it look okay?
Yes, that's great. Thanks.
Great. Yeah, this is a case I'm still actively managing, as I guess a lot of these are. Young guy, 26 years old, originally came to me just through the ER, had a month of worsening imbalance, also some headaches, also reported some numbness and paresthesias in his left arm, but still extremely active guy, you know, playing basketball, this kind of stuff. Had a CT and then an MRI. That picture there is from his original MRI, August of 2017. A large cystic lesion there with that laterally situated nodule. Obviously, we've done a lot of talk already here about, you know, angiogram. We did not do that here, and, you know, we don't need to kind of probe that further. Upon further questioning, very clear VHL picture, even though he himself had never gotten any kind of screening, uninsured, and just, you know, never really followed up. So, you know, we evaluated him as an inpatient outside of a ton of pancreatic cysts, had no pheo, had normal retina, did have a cervical lesion on MRI of the total spine, which we did, and we'll get to that in a little bit. So this was a clear, you know, case for surgical resection, had no issues there. His ataxia and headaches improved. The arm numbness remained an issue. And obviously we felt that the arm numbness was due to this mass here in the cervical spinal cord. My plan at that time was, because he just underwent the suboccipital craniotomy, was just to wait on this a little bit, see what happened with the symptoms. I saw him somewhere in the 3 to 4 month range after the operation, and repeated the MRI at that time. And his symptoms subjectively actually were getting worse. Just the intensity of the paresthesias and the numbness. The MRI at that time was stable, but given the symptom progression and just the way this looked, we took him for surgery here, which went fine, had no issues. You know, one question, we can kind of circle back to this, Russ. I just, you know, in terms of dealing with these, you know, these are really in that kind of peeled or kind of borderline intramedullary, true intramedullary cases. But, you know, are there times where you open up a little bit into the syrinx to try to help decompress that? Or is this something where you just, you know, remove the tumor itself and allow the syrinx to resolve, which, to kind of just interject, you could see that MRI in May, which is 4 months after that immediate post-MRI, you could see significant interval resolution over a 4-month period of the syrinx. So I was just wondering, is there anything that you do surgically up front if you're dealing with a large syrinx in these tumors?
No, it's a great case, Simon. And so typically we try to avoid entering the syrinx at all.
Okay.
Because it creates, if these have an extramedullary, or if you have to split the cord, do a myelotomy, the pressure will deliver the tumor out, because we'll circumferentially go around it, release it from the peel, the pia that's holding it in. And over time, the tumor will just deliver itself out. So we try to, but if we decompress the syrinx, then the pulsations of the spinal cord and CSF become a factor. You're kind of operating on a moving target at that point. And so we'll leave that alone. And to Walter's point, and normally I stress that it's a great point. It's just take this out, it will go away. We did a series of scans a number of years ago watching these syrinxes decompress, and it takes about 7 days before they collapse. And sometimes they don't go away. The only question I have about this syrinx is there a small hemangioblastoma at the obex that's keeping it going? Because the other thing we did see was even very small tumors in association, proximity to them, could keep the syrinxes kind of smoldering. Now, I think this is a dead syrinx just because of the collapse. But I was looking at your initial films, and it looked like there's a little bit of enhancement right in the obex region near that, what looks like syringal bulbia at the top. And I don't know if it's driving this to keep that syrinx open a little as well, or it may be nothing. It just may be a continuation.
Yeah, we didn't see. It's a great question. I mean, I'll look back at all the imaging. It's not something that I saw. It's not something that was read.
Yeah.
But I'll reconsider. But this case goes on a little bit more, actually. So this is the May 2018 MRI, 4 months after we removed the cervical hemangioblastoma. No residual enhancement. The syrinx really dramatically reduced. And I kind of have a little bit of a curveball here. So then he sees me 4 to 5 months after that. He's got numbness and paresthesias that are getting even worse. He got some symptom improvement or stabilization kind of on that border, but now his symptoms are actually getting worse. And he's telling me that he's getting some shock-like pains down the arm. Mm-hmm. So we repeat the MRI. Now, I knew I should have put this in. It's just complicated with all the images, but we knew he had a thoracic hemangioblastoma.
Yeah.
Okay, so I'm showing that here in the bottom left of the screen. That's obviously just a zoomed in sagittal, and that's an axial view. And these are the MRIs, also cervical. And you can see now that from May to October, he now has the syrinx is increased again. Mm-hmm. Not so much in the thoracic. I characterize the worsening of the syrinx really from the original hemangioblastoma site caudal to that. Mm-hmm. Not much change kind of up by the obex. And we re-image again the thoracic MRI, and this lesion had been stable. We did a total spine MRI initially, knew about this, and wasn't as large, wasn't as nasty appearing as the cervical, so we just kind of tabled it. So at this point, I just decided to continue observation. I wasn't enthusiastic about going in on the thoracic. I just wanted to kind of get more data points. We went fairly long on the symptoms weren't horrible. They were occasionally had some bad pain, but otherwise neurologically was okay. So then we go to July and we get an MRI again, and he's stable. His symptoms are stable at that time. The syrinx is stable both in the cervical and thoracic region. So we said, okay, let's continue to observe. So now we got this more recent MRI in January. And now you can see that the cervical syrinx, and that's what this MRI picture looks, no question worse, loculated and just larger, and above the lesion site as well. Thoracic syrinx roughly stable, so it's really the cervical syrinx that's been dynamic. Yeah. They're all continuous, obviously.
Yeah.
The thoracic hemangioblastoma looks stable. He now is talking a little bit more about some kind of radiculopathy that would correlate to the location of that. And so I've had a hard time with them. These are the questions I would have for, is the first question, is the worsening syrinx, which is now above the original hemangioblastoma, do you think it's related to this very downstream, very caudal thoracic hemangioblastoma? Is that our best explanation for that, or do we, like you mentioned, kind of look at
if there's nothing in the brainstem, and it may just have been a little vessel crossing the brainstem that I saw in that first cut you showed, because then I saw that syringal bulbia, I thought, oh, maybe that. But absolutely, and what I didn't show, when we were looking at those syrinxes, we would take out a tumor just like you did, and there could be a small tumor 4 levels down, no syrinx, no edema, and then suddenly several months later or years later, we'd see it driving the same syrinx. Yeah. So these are all, and what happens is, if you remember that MRI with that contrast extravasation, they're just finding, and then there's a path of least resistance in the previous syrinx cavity. So this, if there's no other tumors associated with the syrinx, it would be that thoracic tumor that's driving it. And I just didn't have time to show all that, but we saw that repetitively, even with tumors that, were 2 or 3 millimeters in size. that had some association downstream, they could keep driving a syrinx. It goes back to the thing I didn't say. Look at those tumors that formed edema grew. So it was not a size phenomena that drove the syrinx or cyst size in any of those spinal cord or cerebellar tumors. It really was just the permeability profile of the tumor. So I really do think it's probably your thoracic tumor if there's no other tumor in proximity.
Yeah, that's the only one left. So
yeah, it's got to be that then.
I guess if that wasn't there, this other question I had was, how often do you find yourself treating the syrinx directly? We know obviously as neurosurgeons that shunting these syrinx, especially this oculated syrinx, is probably a fool's errand. How many times have you felt forced into that circumstance?
So like your case, I've never seen a circumstance except in occasional tethering, but even the tethering won't cause that. Never seen a circumstance where it wasn't driven by a tumor in another location.
Okay. Yeah. Appreciate it. Thank you.
No, great case.
Okay, thanks, Simon. John?
Let me just share my screen here. All right, so thanks, Mike, for inviting me to be a part of it, part of this. That's not letting me advance. There we go. So this case is going to be more straightforward, but hopefully it will let the panel kind of discuss a little bit about sporadic hemangioblastomas and recurrence. So this is a 25-year-old lady who I saw who had a history of a previously resected cerebellar hemangioblastoma about 3 years before I met her, who initially presented to my clinic because of some imaging she'd had in the ER where she presented with nausea and headache for 10 days. Her past medical history really just significant for this hemangioblastoma, which had been treated, and I'll kind of show those pictures. She had undergone genetic testing, which was negative, and on exam, it was really, she didn't have any dysmetriary ataxia or anything. So she had initially presented to an ER 3 years prior with headaches, nausea, vomiting, and an ataxic gait. This was her lesion. I think it was about 5 centimeters. There's a mural nodule there. You know, effacement of the fourth ventricle, hydrocephalus. And so she underwent resection. And so this was, she got an unplanned 2-stage resection, basically. The post-op MRI from her first surgery is shown on the top, and you can see that the enhancing nodule is still there. And in looking through the records, I think that the surgeon at the time was sort of thinking of this as a JPA rather than a hemangioblastoma. So they got this MRI, and then 2 days later went back and I think got more of the nodule out. And so this was the post-op MRI after the second operation. And then she was then lost to follow-up for 3 years, didn't have any further imaging to follow this. And then started to develop headaches and symptoms reminiscent of what she had had before. And this was the MRI that she came to me with. So in the region where her initial nodule was, there was a small enhancing nodule, and it was really quite small. I had to get a volumetric scan with thin slices to even really be able to see it. Because of the headaches and the recurrence, I offered her a repeat resection to go in and try to take this out. The initial approach to the lesion had been this kind of small paramedian incision with a craniotomy, and they had gone through the cerebellar hemisphere to get to the lesion. So I didn't like any of that, and so I decided to just do a large suboccipital craniotomy and come over the superior surface of the cerebellum. And this is what I saw when I did that. You can see just the kind of obvious hemangioblastoma there. I used ICG just because I wanted to, you know, obviously not necessary, but I just wanted to use it to try and see if I could visualize the vascular pattern and try to attack the side of the lesion that the blood supply was coming from. And so that turned out to be the medial side of the lesion here, and anterior. And so resected the enhancing nodule. As you can see, a pretty straightforward small nodule. And this is her post-op MRI. And so surgery was here recently, and she's been doing well. So yeah, I guess, you meant, with these cases, you guys have been talking about kind of the principles of resection, taking the blood supply, preserving the draining veins. Maybe this could be a case to talk a little bit about recurrence and what are factors that would cause you to have a patient end up in this kind of situation.
Yeah, so I think, so there's been studies with recurrence, and these typically were older in the sense of when microscopes weren't as frequently used, where there was some residual potentially, or there was bleeding and maybe some of the tumor was remained. And what they found in those studies was that the recurrence rates were incredibly high if the tumor wasn't resected. Not surprising, but the tumor in some cases appeared to be almost more aggressive with progression for reasons that weren't entirely clear. But I mean, you show a very nice look at this. And I think, I can't remember if you said she's symptomatic, but that cyst is going to progress. And it goes back to what Simon said. Even the tiniest parts of these tumors can really drive cyst formation that can be dramatic. It takes a very small tumor to drive a dramatic cyst. And, this is a great case. The one thing that has been shown in sporadics that have not been removed where there was significant blood loss, and I know you didn't have that, is you can see what sometimes is the leptomeningeal or hemangioblastomatosis. That's the scenario in sporadic cases preferentially where that has been seen for reasons that aren't understood. But those can be pretty dramatic cases in a few years. But this is not in that category at all, but a very nice case and nice job.
Do you, you talked quite a bit about the approach of trying to be very judicious with surgery in patients with VHL, because you're going to have to kind of get them through many years. And so you want to be careful about how many times you operate on them and make sure your indications are really strong. Do you carry that same kind of mindset in sporadic cases, or is there any kind of different nuances to the thinking in those cases?
That's a really good question. And, I was talking to Paul McCormick a few years ago, and I was of the mindset that there's two different algorithms. One's for sporadic, one's for VHL. VHL, you wait to very early symptom formation, headache, radiculopathy, kind of neck. We even use neck pain with cervical tumors as a criteria. But over time, and Paul was saying, he'll watch a sporadic hemangioblastoma in the context of it looks like hemangioblastoma on MRI, and it's worth watching because do an early 3-month scan, you can see, and if they follow the course like they do with VHL, maybe some of these don't require removal. I think that's if you have a young patient, they're going to require removal at some point. With all these incidental MRIs, we're seeing these more and more frequently, and I'm open-minded to both ways from a sporadic perspective.
Yeah.
The question will be: was this always comes up with the cyst? Is this a JPA? Type of thing.
Yeah.
Great case though.
Yeah, a great case, John. That idea of going trans-cyst versus, outside the cortex for these small mural nodule ones is also an interesting point. I think the idea of ICG to illuminate it helps, but, sometimes I found, you want to decompress the cyst fast, and then when you're in there, you're like, okay, let me just go towards the nodule. But I feel like it is a little bit sometimes more fuzzy to see the outlines of the nodule coming inside out from the cyst versus then coming back around after it's decompressed outside the brain.
Yeah, that's a good point.
Okay, great. Well, it's 6:30, and I know we've stole a lot of time from everybody, especially Dr. Lonzer. So I just want to say thank you again for your time and comments to Dr. Lonzer and the panelists. I really appreciate it. I hope you guys stay safe, and we'll talk soon.
You too. Thanks so much. It's really been an honor to be part of this. I really appreciate it. Thanks, you guys.
Thanks, Mike.
Take care.